ஹாய், இன்றைக்கி நாம் JIP DYK ப்ரோக்ராமில் நாம் பார்க்க போகிற டாபிக் என்னங்கிறது பார்ப்போம். ஸோ how to approach anemia. Of course, I strongly believe that you encounter the patients with anemia on daily basis, but when you see that the patient is suffering from anemia, we are simply tempted to prescribe all kind of iron supplements and folic acid without much evaluation. This often happens in our practice. I think that definitely you would agree that one. But I could say the anemia can be evaluated by many other means, of course. By means of clinical finding, of course you can differentiate. For example, if somebody has iron deficiency anemia, they may have alopecia and they may have koilonychia, I mean the spoon shaped nails, and they will have the signs of pica. So they want to eat non-food materials, something like chalks and so on. These may be suggestive of iron deficiency anemia. For example, in B12 deficiency, they may have hyperpigmentation over the knuckles and they may have some kind of GI symptoms, resistant chronic diarrhea, and they may have neurological symptoms starting from signs of peripheral neuropathy to involvement of spinal cord in the form of subacute combined degeneration of posterior column and so on. But if you want to differentiate anemia truly, then the patient must undergo rigorous investigation starting from all kind of routine complete blood count and peripheral smear, and you have LDH, serum ferritin and iron profile, serum B12 and folic acid and methyl malonic acid. There are so many assays. Then finally patient may end up in bone marrow evaluation also. But here this program going to address the one single important investigation by which you can differentiate the types of anemia on which definitely you can recommend justified and genuine pharmacological therapy. So what is the most important simple investigation by which you can differentiate anemia? The most important investigation I specifically clinch on to is mean corpuscular volume, or otherwise called MCV. So I have been witnessing many of our practitioners are simply overlooking the RBC indices, something like mean corpuscular volume, MCV, MCH, MCHC, red cell distribution width, and once they see the parameter they simply overlook. Then probably I think that this is the high time where you should understand the importance of this hematological indices. So how will you define anemia? Generally, when hemoglobin is less than 12 gram in female, we used to say they have anemia. In the case of male, if it is less than 13.5 gram. So when you find the hemoglobin is lesser than the recommended value, look at mean corpuscular volume. Okay. So normally mean corpuscular volume denotes the cell size basically. Normal mean corpuscular volume is 80 to 100 femtoliter FL. So hereafter I would like to see, or I would like to insist that whenever you look at the complete blood count, you just go in search of mean corpuscular volume, otherwise called MCV. Okay. Then this MCV, either it may be placed below 80 or between 80 to 100, that is considered normal, or more than 100 femtoliter, that is higher value. Okay. Suppose if mean corpuscular volume is lesser than 80, then you have 4 important differential diagnoses. For all UK exam, we used to go through that one exam that is called IELTS exam. Okay. So instead of remembering IELTS, I could say you remember ILTS. You just remember ILTS. The ILTS mnemonic denotes the differential diagnosis of decreased mean corpuscular volume, or otherwise called microcyte, because mean corpuscular volume lesser means the size will be lesser. So when you do peripheral smear, it simply correlates with, they may report microcytic anemia. Okay. So when MCV is lesser than 80, otherwise called microcytes, invoke 4 differential diagnoses. The mnemonic would be ILTS. What is I? I stands for iron deficiency anemia, L stands for lead poisoning, T stands for thalassemia, and S stands for sideroblastic anemia. These are the 4 important causes. Please remember that among these 4 important causes, 90 to 95% of microcytic anemia, or otherwise called a decreased mean corpuscular volume, is nothing but iron deficiency anemia. For all practical purposes, decreased MCV, most of the time we are dealing with iron deficiency anemia. What about other 3 differential diagnoses? Generally lead poisoning, I have never encountered lead poisoning as such other than reading in theoretical forum. But lead poisoning may be common in childhood age group or in older individual. It may present as neurological problem or it may present as GI symptoms. So generally when you do heavy metal profile, okay, suppose if you suspect heavy metal poisoning in the case of peripheral neuropathy, at that time we may detect increased level of lead poison, increased level of lead in the serum. Otherwise, lead poisoning is one of the important cause for microcytic anemia. Then what about another one? Thalassemia, common in childhood. And third one, sideroblastic anemia. Sideroblastic anemia is the one where the iron is not able to be incorporated in the RBC. The sideroblastic anemia, the pathophysiology would be the irons are plenty in the serum. So everything is plenty for the production of hemoglobin, but there is some kind of pathophysiological process which interferes with entry of iron into hemoglobin, resulting in sideroblastic anemia. So this is occurring in hereditary form or acquired form. When you say acquired form, it may be seen in B6 deficiency and of course lead poisoning, copper deficiency and so on. So among these 4 causes, iron deficiency anemia is the most important cause for decreased MCV. So when you find MCV below 80, then probably you are sure that you are dealing with iron deficiency anemia. So when somebody is decreased with decreased MCV, then probably you may be justified in prescribing, of course, all kind of iron supplement and folic acid. But when MCV is lesser than 80, denoting iron deficiency anemia, so the causes of iron deficiency anemia may be nutritional, where definitely iron rich diet and iron supplementation is warranted. One more important cause for iron deficiency anemia more than 40 years, blood loss. Okay, especially around the age of 60 years, blood loss from GI malignancy is very common. So somebody presents with hemoglobin 7 gram, okay, MCV is somewhere around 65 or 70, instead of thinking nutritional deficiency which may require simple iron supplementation in the form of oral or IV, but you have to think of blood loss. This patient has to be evaluated for GI malignancy. So whenever you look at decreased MCV, think of these 4 differential diagnoses: iron deficiency anemia, L for lead poisoning, T for thalassemia, S for sideroblastic anemia, ILTS. Once you are very sure that you are dealing with iron deficiency anemia with decreased MCV, you are justified in recommending iron and folic acid. But when somebody presents with hemoglobin around 7 gram or 8 gram with normal MCV or increased MCV, don't recommend iron and folic acid very hastily. You have to explore the other causes of normal MCV and increased MCV before you recommend iron and folic supplementation. In next session, we explore the causes for normal MCV and increased MCV.